Today we'll be studying the short cases, and our first case is nothing but diabetic foot. Coming to the introduction, diabetic foot is a serious complication of diabetes mellitus, characterized by infection, ulceration, or gangrene due to their combination of neuropathy, peripheral vascular disease, and poor wound healing. It is a major cause of lower limb amputation worldwide and significantly impacts the quality of life. Early detection and proper management are crucial in preventing the severe complications of diabetic foot. Coming to the pathophysiology, first being the peripheral neuropathy, which is the most common, it can be divided into the sensory neuropathy, motor neuropathy, and autonomic neuropathy. Sensory neuropathy being the first to be affected, which leads to loss of pain, temperature sensation, leading to unnoticed injuries. Motor neuropathy leads to weakness of the intrinsic foot muscles, which results in foot deformities like claw toes, hammer toes, and leading to abnormal pressure points and ulcerations. Autonomic neuropathy occurs at last, which decreases the sweat production, finally leading to dry and crackled skin, making it prone to infections. Peripheral vascular disease being the second in the pathophysiology list, which causes atherosclerosis of the lower limb arteries, leads to production for reduced blood supply, causing ischemia and delayed wound healing. The common sites of arterial occlusion being the popliteal artery, tibial artery, and femoral artery. Severe ischemia leads to gangrene and limb necrosis. Thirdly, infection and impaired wound healing. Hyperglycemia impairs the immune function, making the patients prone to infections. Common causative organisms being the Staphylococcus aureus, Streptococcus, Pseudomonas, and anaerobes. Foot ulcers get easily infected, leading to cellulitis, abscesses, and osteomyelitis. Risk factors for diabetes foot: uncontrolled diabetes, that is long-standing and poor glycemic control; smoking and hypertension, that is which aggravates the peripheral vascular diseases; dyslipidemia, being the high LDL and low HDL, which promotes atherosclerosis. Previous foot ulcers or amputations also increases the high risk. Obesity and sedentary lifestyle, increased foot pressure and poor circulation. Poor foot hygiene and ill-fitting shoes also increases the ulceration and infections. Classification of the foot ulcers. This is named as Wagner's classification. Grade 0 being intact skin, high risk foot calluses and deformities. Grade 1 superficial ulcer, that is partial or full thickness ulcers. Grade 2 deep ulcers involving tendons, muscles or joints without abscess or osteomyelitis. Grade 3 being the deep ulcers with abscesses and osteomyelitis or joint infection. Grade 4 being the localized gangrene, toe, forefoot or heel. Grade 5 extensive gangrene requiring amputation of the affected limb. Texas classification system includes stage 1 without any infection or ischemia, stage B with infection, stage C with ischemia, and stage D both infection as well as ischemia. Clinical symptoms of diabetic foot. Symptoms includes non-healing foot ulcer, which are painless due to neuropathy, foot pain, cramping or claudication, which suggests ischemic pain. Swelling and redness, that is signs of infections. Numbness, tinglings or burning sensations, that is neuropathy symptoms. Blackish discoloration of the toes or foot suggests the gangrene formation. Signs of diabetic foot are ulcers with callous edges, that are neuropathic ulcers; cold, pale foot with absent pulses, which suggests ischemic foot; swollen, red and warm foot, that is infected diabetic foot; foot deformities like claw toes, hammer toes, charcot foot, etc. Foul smelling pus or necrotic tissue due to the advanced infections. How will you diagnose this case? So first comes the role of clinical examination. First being inspection. We have to look at the ulcers, deformities, calluses and gangrenes. Then we should proceed for the palpation. That is, check for the temperature, tenderness, pulses, indurations, and furthermore, which we will be discussing at the later part. Also, we have to feel for the pulses, that is dorsalis pedis or posterior tibial and other pulses also. Sensory testing includes monofilament testings with 10 gram monofilament, which we'll be discussing later on. Some other tests being the vibrating test, which 120 Hz tuning fork, and pinprick and temperature testings. Laboratory testings essentially includes the monitoring of the blood sugar, that is fasting and postprandial blood sugar, as well as long-term glycemic control with the help of HbA1c testing. We have to also do the complete blood count, that is CBC, C-reactive protein, CRP, procalcitonin, for assessment of the infection and its severity. Wound culture and sensitivity is must at the beginning of the uh, beginning of the that management to identify the exact bacterial pathogen before starting the definitive antibiotic therapy. Coming to the radiological investigations, there is the imaging studies of X-rays of the foot, which is useful in detecting osteomyelitis, that is the bone infection, fractures, or Charcot's foot changes. Charcot foot also we will be discussing with pictures in a later part. Doppler ultrasound for evaluation of the peripheral arterial diseases. Sometimes MRI is needed to detect deep abscesses or soft tissue infections. CT angiography for detecting severe ischemia, which assesses the arterial blockage and its level as well. Management of diabetic foot. First comes the general measures, that is the strict glycemic control, maintaining HbA1c below 7% using insulin or oral hypoglycemic agents. Smoking essentially needs to be stopped as soon as possible, and also we need to monitor as well as to control the blood pressure to prevent vascular complications associated with diabetes mellitus. Regular foot care is of utmost importance by daily inspection, washing, moisturizing, and also the caring of the nails. Proper footwear with soft, well-fitting shoes which protects with proper padding. Wound care and ulcer management includes debridement by surgical, enzymatic, or autolytic methods, that is the removal of the dead tissue to promote the healing. Dressing includes moist dressing like hydrocolloids and hydrogel dressing. Silver impregnated dressings or iodine based dressings are also used. Offloading technique, that is total contact casting (TCC), reduces the pressure on the ulcer. Custom foot orthotics and specialized shoes are also used for offloading techniques. Antibiotic therapies for infected diabetic foot ulcers include mild infections, oral antibiotics like amoxicillin and clavulanic acid, clindamycin, or doxycycline. Moderate to severe infections are controlled with IV antibiotics like piperacillin, tazobactam, meropenem, vancomycin for methicillin-resistant Staphylococcus aureus. Duration of antibiotics should be 2 to 6 weeks depending on the severity and osteomyelitis and involvement of the affected limb. Vascular management for ischemic foot and gangrene. Peripheral angioplasty or stenting, which improves the blood supply in peripheral vascular disease patients. Bypass surgery like femoropopliteal bypass for severe ischemic limb. Surgical intervention are used for advanced diseases like incision and drainage for foot abscesses, partial toe or foot amputation if localized gangrene is present. Major limb amputation, that is below knee or above knee amputations if severe gangrene, sepsis, or non-salvageable limb is present. Complications of diabetic foot include cellulitis and deep tissue infections. Osteomyelitis, bone infection, may require prolonged antibiotic or even surgery. Septic shock and multi-organ failure due to uncontrolled infection also sometimes occur. Lower limb amputation leading to permanent disability of the patient. How to prevent this diabetic foot? That is daily foot inspection and proper hygiene. Avoid walking barefoot. Routine podiatric care. Regular visit to the foot specialist. Regular exercise as well as blood sugar control. Diabetic foot is a serious complication of diabetes resulting from neuropathy, ischemia, and infection. Early screening, wound care, strict glycemic control, and vascular interventions can prevent amputation and improve outcomes of diabetic foot. A multidisciplinary approach involving endocrinologists, vascular surgeons, podiatrists, and physiotherapists ensures better management and quality of life for diabetic patients. Now, some of the questions that may be asked in a case of diabetic foot when you get a diabetic foot as a short case is what are the points to describe a case of diabetic foot? Under inspection, we should first see the entire deformity of the affected as well as the normal limb. Also, we should look for the skin's, hair, and nail conditions, dry, scaly, and hyperpigmented skin, as well as sparse hair and onychodystrophy, that is the abnormal nail changes are often observed in cases of diabetic foot. If any ulcer is present, then we have to describe the ulcer. Also, the surrounding skin, that is the whether any hyperpigmentation, induration, that also has to be mentioned. Exposed tendons and bones if visible. Gangrenous changes and its level has to be mentioned in inspection. Presence of any dilated veins and its level, and also the whether it is present in the greater saphenous or lesser saphenous vein territories. Presence of any discharge, whether it being serous, seropurulent, purulent, or any hemorrhagic discharges. We should also look for the pressure points for callosities and ulcers. Coming to the palpation, in palpation basically we confirm the findings in inspection, particularly in superficial, that is the temperature and tenderness we have to see. The inspection findings of ulcer we have to confirm, as well as we have to palpate for the base and other inspection findings we need to confirm this with these palpation findings. Also, we should check for the surrounding indurations. Also, capillary refilling time in the nails if possible. The peripheral limb ischemia should be assessed. Edema and its level should also be inspected in the palpation. We should also check for associated lymphadenopathy. That is, if in case of lower limb, the inguinal group and axillary group, in case of upper limbs and neck nodes. We should palpate for any thickened nerves. Also, we should check for all the peripheral pulsations because diabetes is a systemic disease and it usually involves all the arteries. So we should check for all the pulsations. Also, we should check for sensations and movements. Lastly, reflexes if applicable in diabetic foot. Some questions may be asked regarding the deformities in cases of diabetic foot. Here we can see the claw or hammer toe. That is a hammer toe first. Secondly, the claw toe and mallet toe. First picture we can see all these deformities. Secondly, the calluses, hallux valgus. That is lateralization of the first metacarpophalangeal joint, which can be seen in the second picture. Thirdly, we have seen some picture of amputated third toe. Also, pes planus, pes cavus, that is plain foot and also exacerbated plantar arch. Metatarsal heights are also prominent, which can be seen in the last image. So sometimes you may be asked that what are all these conditions? These are nothing but the Charcot foot syndrome, which can be visualized better in these images as well as the X-ray images. We can see the rocker bottom deformity, that is the rounding of the lower part, that is the eversion of the plantar arches. Another question may be asked regarding diabetic foot. After how many years usually diabetic foot occurs? That is, usually it may take up to 10 years because this much time is approximately required for neuropathy to develop. So how neuropathy occurs? This occurs because of the vessels supplying the nerve that gets blocked by atherosclerosis. Moreover, the myelin sheath formation is also defective. Also, there is edema of the nerve trunk, which ultimately hampers the neurotransmission. In case of lower limb, we may be asked which nerves are affected and in which order. This is first the somatic sensory, then the somatic motor, and lastly the autonomic nerves. They may be asked what are the manifestations of autonomic nerve problems. This will be the skin secretions will be diminished. So this will form some skin will be dry, atrophic, and also there will be ulcerations, itchings, and secondly we'll be having the motor deformities, motor involvement. So how muscles are involved? Firstly, the intrinsic muscle will be involved. This leads to abnormal weight distribution and finally affecting the arches. And later on, it will also affect the other extrinsic muscles. What are the problems one may face during palpation of the pulsations? The pulsations may be difficult to feel due to the presence of edema as well as the thickened arterial wall. So we have discussed previously regarding the monofilament test. It is nothing but a monofilament of 10 gram is used. In the first image, we can see that the correct way of applying pressure. That for performance of this test, the device is placed perpendicular to the skin. Here we can see, and with pressure, the pressure should be applied until the monofilament is buckles. See, and this is a torn out monofilament. So this is not suitable for the test, and also this is the incorrect method of application of the pressure. Okay, what are the pressure points where we have to check? Total 10 points, that is 9 points in the plantar aspect and 1 point in the dorsal aspect. These are seen first, second, and lastly the last fifth toe. And also we can see 4, 5, 6 in the distal arch. In the mid part, 7 and 8, and at the heel, it's the ninth. One may be asked about the ABPI. It is nothing but the ankle brachial pressure index. It is a test that measures the ratio of blood pressure in your ankle to your arm. Usually, normal ABPI is more than zero point 0.9. Zero point 0.7 to 0.89 is mild ischemia. Zero point 0.5 to 0.69 is moderate ischemia, and less than zero point 0.5 is severe, that is the rest pain. And if it is less than zero point 0.3, that is considered as a critical ischemia, that is tissue necrosis has already developed. What is negative pressure wound therapy? This is a method particularly used for non-healing ulcers. This can also be used in cases of diabetic foot. So this is the device that is used for negative pressure wound therapy. Below we have seen the ulcer. Here is the ulcer with the surrounding tissue with a attached transparent sheet from which the negative pressure is connected to the instrument machine. So this is also known as the vacuum assisted closure therapy. It is a medical technique that uses negative pressure to promote healing in acute or and chronic wounds. It involves the application of the controlled vacuum environment to the wound site, which facilitates faster healing by removing exudates, reducing edema, and improving the blood flow. Procedure: first, we have to apply a sterile dressing in the wound bed. Then, above that, we'll apply the adhesive drape, which covers as well as seal the wound as airtight. Then in the middle, a tube is connected from the foam dressing to the vacuum pump, which creates negative pressure. The vacuum pump is set to deliver either continuous or intermittent negative pressure, helping to draw out fluids from promote healing. Now, what are the indications? As we have already discussed, the chronic wounds, acute wounds, all the his wounds, burns, skin graft, and flaps. In these cases, we can use the negative pressure wound therapy. It is usually contraindicated in cases of malignant nodes, untreated osteomyelitis, presence of necrotic tissue and debris in the base, and actively bleeding or exposed blood vessels, and non-enteric exposed fistulas. Also, we should avoid negative pressure wound therapy. The benefit of negative pressure wound therapy being the accelerated wound healing, reduced edema and bacterial load, promotion of the granulation tissue formation. It manages the wound exudate effectively and minimizes dressing changes, reduces pain and infection risk. What are the disadvantages? It is expensive, can cause pain, discomfort, requires specialized training and monitoring as well as manpower. Risk of tissue damage if improperly applied. May not be suitable for all types of wounds. So this much about the diabetic foot. Hope you have learned the topic well. And if you have any doubt, mention in the comments so that we can discuss in the further lectures. Thank you.